All right, welcome to another special episode of Saka's Is That So? Today, we're going to be speaking to resident Dr. Mohammed Nuru in New York City. Welcome to the show, Mo.
Hey, Saka, pleasure to be on the program.
Of course. All right, man. So why don't we dive straight into it? This will be a bit of a unique episode because we typically speak about venture capital, investing, business, tech, and all that. But we've never had someone in the medical industry speak about their side of things. And so why don't we start off with, in your day-to-day kind of role, where does tech and finance kind of meet the medical world? In what capacities or what tasks or in what ways do you see those two worlds ever meeting on a day-to-day basis?
You know, it's very interesting. I think, so the person, or the Joe on the street, it's hard to imagine that, something like healthcare would have anything to do with finances and, finance and tech. I think the public perception of healthcare is it's this very altruistic field, which it is, and it's very bioscience based and it's very sort of hands-on, but tech and finances are the probably the foundation of what is one of the largest industries in the US and if not the world, really. So it plays a lot in my day-to-day as a resident, from what we call our EHR system, which is the electronic healthcare record. It's sort of the platform on which we document interactions with patients, how we set billing for procedures, how we place orders, how we communicate amongst ourselves within healthcare organizations. I mean, you have multiple units communicating with each other at a given time under sort of a closed like firewalls and what have you. But on the day-to-day, it's how we conduct business now, anyway, in the 21st century.
Yeah. The thing is, growing up, I always remember people saying like doctor's handwriting is absolutely, abysmal, right? That's like the common thing that you hear. And then, I was surprised when I'd go to hospitals and they still use like archaic, like, handwritten notes to do things and whatnot. And I'm just thinking, why don't you all just get tablets? It's much quicker, safer. There's no room for misinterpretation. Is it still as analog as it once was, or is everything really digital now? And if it isn't, are there any like barriers as to why things aren't as digitized as maybe in other industries?
Mm-hmm. For the most part, I'd say it's pretty digitized now. It's pretty digitized. I think the last hill in a sort of medicine to where it was more analog was with script writing. So whenever you prescribe a medication, let's say, someone was admitted into the hospital and now they're discharged and you want them to pick up medications at a pharmacy or something, it used to be that you would have to print out a script and fill it out with specific information that they would take to the pharmacy and they would get the medication. I mean, there's some institutions that still do that, but for the most part, a lot of people just e-prescribe. So it's sort of put into your computer, you order from a certain pharmacy or it's sent to a certain pharmacy, but you also have a specific code, attached to your license that you could put in that sort of, on the pharmacy side, they can identify that as, okay, this is a legitimate prescription from XYZ. So for the most part, we've kind of done away with sort of handwritten notes as far as how they make it to the general public anyway. Amongst ourselves, we still have our own little notes and things that we take down, which are, between physicians are even difficult to decode.
Yeah.
Even within physicians, there's some physicians that will write something down and then later on in the day, you might not recognize what you put down, which is pretty funny.
Yeah. Actually, one of my friends, unfortunately, he lost his mom as a result of like a doctor writing down something and people couldn't actually understand what was written. It was supposed to be like a blood thickener and they did the complete opposite and they got like a blood thinner. And then his mom ended up passing away. And it's, it was one of those things where it's like, man, that's so unfortunate because, this is something that if it was like a drop down, like a scroll kind of thing, if someone chose something, there's no misinterpretation because of handwriting and things of that nature. But it's good to hear that things are moving forward. And actually today I just read that there was something called, is it Palm 2? It's like a chat GPT, like an AI script. And it just passed like the medical exam. It got like an 86.5% like score. So I'm thinking like from your perspective, what are the chances of like Chat GPT-3 or AI taking over like a doctor's job, or there's some things that it'll never be able to do. You know what I mean?
Yeah, AI in healthcare space. I mean, it's a big topic, a very interesting field. One I'm sort of very much interested in figuring out research and sort of use situations for AI in my research. But I think the practice of medicine is it's so intricate and complex, and there's a lot of pattern recognition, which AI does really well when it's well trained. But there's a human element uh, that still evades AI at this time. It's very easy to sort of rely on uh, sort of past experience, sort of aggregated past experience to make a medical decision and miss sort of nuances of particular cases. If an AI, essentially, if an AI system has never seen something, a variation of something before, it's less likely to know what to do or be as creative in coming up with solutions. There are a lot of practical things in healthcare in which you kind of have to use creativity to get around problems. So AI might not be there yet, but as a tool to help sort of streamline medical processes, I can see it being very, very useful to physicians, in that it can sort of transform the way we practice medicine for the better, for improved lifestyle, better revenue generation, all of that. So I think it has a space. I mean, it's already it's been highly involved in other fields and study. It's only a matter of time before medicine has its own sort of day with
Yeah.
AI.
Because I mean, when you think of going to the doctor, a lot of people get a second opinion, right? Because you're, like you mentioned, you're relying on the aggregate experience of that doctor. And that's why people like established doctors, 50, 60 years old, that have been there, done that, right? The more experience, the better. At least that's what my layman brain tells me, or people from the outside, right? And so I'm thinking, I mean, what could be more experienced than AI that can source from thousands of potential cases that are out there? Or if I want to get a second opinion, AI can be that second opinion instead of going to another doctor, because I can just put in my symptoms. And much like Google tells you, when you have a pimple on your face, you're dying of cardiac arrest, or you have the worst symptoms, or, like anytime you type it into Google, it tells you the worst of the worst. I feel like AI will be able to give some of that nuance. But if there was any use case you could think of right now that you would love to apply AI in, especially in the medical field, what do you think that would be? Would it be actually diagnosing, or would it be like reading diagrams where as a doctor, you're likely to miss something on a chart? Like, what would be ways you would love to apply it?
I mean, great ways to apply AI in medicine. I think in the streamlining process, I think just broadly speaking, AI is probably in healthcare right now, as I can imagine, it'll be most useful in kind of getting a whole bunch of, say you have a whole lot of input that typically a physician would have to review on their own, bit by bit by bit. AI would be great in taking all of those inputs and saying, these are the most important things you should review, and then simplifying the rest of it. I guess I can only really explain this with like a case example. For instance, radiologists. So radiologists are physicians, medically trained, that review imaging, medical imaging, CTs, MRIs, X-rays, that are ordered by other physicians within a hospital system that are supposed to aid for diagnosis or treatment plans. Mm-hmm. Now, because it's an image-based sort of exercise, there are patterns that even radiologists have developed. They're code names for signs that mean certain diagnoses. We already know that AI, there's a form of AI, it's called convolutional neural networks. And there are specific AI algorithms that are used to sort of solve problems related to images, right? So you can train one of these AI systems to, based off of backlogged data, that's been attached to, a diagnosis. You can train them to identify these diagnoses. And this is something that could be routinely or could reduce the workload on radiologists by feeding all that input to them. And then the radiologist simply just has to confirm if, the read is, if it's correct or if it's inaccurate, or, there might be, in a pile of different X-ray images or CT images, there might be 4 that are sort of out of the ordinary, and the remaining 30 are just routine, normal scan. The AI system, say, today's radiologist shows up to work at, 7 a.m., just so they can get through, 30 images before they can start their day and get more images. You can have an AI system at the head of the morning, read all those images. The radiologist can come in at 9 a.m. knowing that 90% of those images have been read, and there's a corresponding readout, maybe like a one-liner for each image, and their attention can only be or should only be put on the very complicated images, the 3 images. So in that, you've saved someone maybe 2 or 3 hours worth of sleep. But that's a very simple example. But things like that, things that can sort of streamline the diagnosis process in a safe manner, at least as AI rolls out and becomes more sort of involved in the healthcare space, I can see that being a great use application.
Yeah, no, I definitely want to come back to the hours worked, because I remember you told me something along the lines of, the number of hours you work, like 12 hours a day, 6 days a week, and all that, and I was blown away because I thought, doctors should be as relaxed as possible, so they're as clear-headed as possible. So we'll definitely speak about the hours worked. But a lot of people are entrepreneurs that listen to this podcast, and some of them might be in the life sciences space where they want to sell into hospitals or come up with new inventions and maybe do a pilot program, right, at a particular hospital and things of that nature. What are some of the avenues that an entrepreneur can go down in order to be successful in this medical space? Are there certain institutions they can go to, certain grants they can go to? In other words, how can they get like a pilot or some new innovation sold into a hospital and actually be successful as an entrepreneur in this space? Do you have any tips or anything that you'd recommend?
I think that's a great question. I think tips, I'd recommend reaching out to physicians that are particularly interested in innovation in the space, because ultimately, entrepreneurs are great at sort of taking ideas or cranking them up into scale and actually sort of figuring out how to mass market an idea. And entrepreneurs are great leaders, so are physicians, but they work in 2 sort of separate realms. You have the physician that has all that basic science knowledge, and they're kind of the practitioner of the space. So they have, by virtue of doing this daily, they see the holes or the opportunities. If you're a particularly innovative person overall, in your own life, you see the holes and opportunities for improvement. So I would recommend entrepreneurs reach out to medical professionals, physicians that are particularly have an eye on improving, healthcare practice. And in that collaboration, I think will be the impetus for actual success in the field, because it's very hard for one or the other to do it alone. From my perspective, there's only so much time to learn medicine, and there's only so much time to learn business and finance and that sort of know-how. Yeah. So collaboration.
Yeah. So do a lot of, I don't want to say medical practitioners, physicians, do a lot of them even try and become entrepreneurs? So when they see problems, do they actually, like, is there a spirit of entrepreneurship and finance or tech within the medical world? Or is it more so you see a lot of problems, but you're just trying to get through the day, like you're just trying to get through the program, you don't have the time to actually be an entrepreneur? Like, in short, is it like 1 or 2% that end up actually even trying to, or end up trying to create a solution to a problem they find? Or the majority of people just like, look, the system is the system, I'm just trying to get through it, get my paycheck, or just help people in the best way possible, or be an actual medical practitioner, as opposed to even trying entrepreneurship?
That's a wonderful question. I couldn't tell you what the percentages are, but I could sort of comment to that vein. I think a lot of physicians in training right now have what we call in medical education sort of a scholarly interest.
Mm.
So there's some physicians that want to be physician scientists. So, on the back end of learning medicine, whatever time they can squeeze, they sort of dedicate to a scholarly activity. Like the research people would be learning how to write papers, how to generate a hypothesis, how to test that hypothesis, and all the related sort of process behind getting approval for a project, getting funding, grants, all that stuff. So that in itself is a whole little career that's attached on or latched on to their medical degree. You have people that are interested in social sciences. So they'll have an MD degree, but then they'll dedicate a fraction of their training to getting an MPH, so a Master's of Public Health. They might be interested in advocacy. They might be interested in lobbying. So they go in that direction. You have a sect of people that are interested in entrepreneurship to various degrees. Some people get MBAs with their MD programs. In fact, there are medical schools that will allow you to take a year out of med school to go to business school. So you can have an MD, MBA. Those are the people that are probably the more traditionally recognized entrepreneurial group.
Mm.
What other examples are there? Those are like the three main ones.
Mm.
So there are people out there, but on the local level, people who might not have those degrees, there's still people that recognize problems, and they try to advocate within their own sort of system. Lobbying with healthcare executives or the immediate superiors about these are things we can change and so on and so forth.
Mm.
So I think a lot of physicians are interested in improving not just quality of care, but quality of the workspace. It's a field filled with people that are very analytical about what they do, and efficiency is something that rings true amongst all those different sort of interests that physicians may decide to attach to like the degree.
Yeah. So why is healthcare so expensive, man? Especially in the US? Like from your perspective, you're working day to day. Like, why is it so expensive?
Yeah, it's a tough question. The costs of healthcare, we can think of it as from a relative perspective to what it used to be and what it is now.
Mm.
And a lot of people will say the reason why it's more expensive than it used to be is in part driven by sort of the rise in our average lifespan,
Mm.
the shift in our demographics. We have older populations now, and it's in a whole bunch of data online, and anyone can look this up, that a large fraction of healthcare costs are actually paid or what's the word, or are spent on people over the age of 60, 65, because as you get older, you develop chronic diseases.
Mm.
We figured out ways with our medications to keep people alive for a longer time. And so they spend, or they require more healthcare services. It's almost something that feeds into itself. It's cyclical. Whereas you have people under the age of 30 that, their total healthcare costs, I think for people under the age of 30 per year is probably something like $2,000 or $3,000 on average, versus people over the age of 50, 65, you may be looking at $20,000 a year, 30, 65. So it goes up. So that's one thing. Another element of it is the epidemic that is obesity, and what obesity does to health overall. Obesity, you have rises in lipids and cholesterol in the blood, and you have vascular disease as a result of that. There are more invasive procedures that need to come into the fold to actually treat conditions. And those invasive procedures require very skilled techniques and procedures that take years to acquire. And in people acquiring those, and people chasing those skills and acquiring those, that's human labor time And then so a dollar amount is ascribed to that. So there's that. And then you think about, how physicians are paid or how the healthcare industry generates, money. And that's a huge topic. I know we sort of chatted a little bit of we would get into, but just to answer your question succinctly, those are some examples why, healthcare is so expensive.
Yeah, actually, that's a good segue. We can go straight into like the economics and how the industry even makes money. And I think with a focus on, I mean, we can start off with salaries as well, because I know a lot of people talk about how doctors are supposedly the guys that make $500,000 a year and their Bugattis and like, but what's the actual reality of someone that is in the early stage of their medical career and then in the later stage? I mean, you have to put student loans into account. Like, what is the actual reality of, I guess, salaries within this medical field? Because during the pandemic, I was hearing of nurses making 150, almost $200,000, $10,000 a week or whatever it is. And then other times I'm hearing like resident doctors that are in their second year are making like 50 grand or 60 grand. And I'm just like, how is that possible that a nurse is making 3 times as much as someone that's a future MD? You know what I mean? So it doesn't make sense to me from the outside looking in. But from your perspective, what's the landscape look like?
Yeah, it's another very interesting question. Physician salaries and compensation are very much set, sort of set. So overall, and it's an interesting question. So overall, the idea behind physician compensation and what value we can ascribe to different procedures. So there's the CMS, which is the Center for Medicare and Medicaid Services, get together with insurance companies in Congress, and they decide how much money or value should be ascribed towards activities in the healthcare space. And they codify this in something called RVUs, relative value units. So a relative value unit is ascribed to a dollar figure. And CMS and insurance companies decide for X procedure equals Y amount of RVUs, and amounts to a certain amount of money. And you have, on the coding side, medically, you have something called CPT codes and ICD codes. So these things, ICD code is sort of, it's a classification of medical diagnoses that are used to establish the basis for claims, medical claims. So you can go to the insurance company and say, I treated this patient for this, and that's establishing that, okay, I need reimbursement for payment.
They just want to add as many things as possible and just be like, hey, this person needs this, this, and this, and this, and this to rack up the number of units or whatever it is, no?
Right, no, it can't work that way because it has to make medical sense for it to work that way. And also you have people that what's the word? You have people that sort of survey. So let's break it down this way. So you have an insurance company. Within an insurance company, you have coders. In fact, there's a large group of coders, and their job is to sift through all these codes. They have manuals, and they decide if whether or not a certain billing pattern should be flagged as not appropriate or passed as appropriate. So on the physician side, you put in all the ICD codes and the CPT codes. This is the diagnosis. These are the procedures that were done, and it's almost algorithmic because there's so much data acquired over time that you would expect with this diagnosis. Here are the possible sort of branches of procedures and labs that should be ordered that make sense. So if something creeps in there that doesn't make sense, then it's flagged, and then the coders reach out to the physician office or the group and say that, oh, this is something. Why was this done? There's an auditing process, is the word I was looking for. So generally, that's how that's sort of policed. But so you have physicians, sort of putting in these ICD codes, these CPT codes, and then you have insurance companies saying, well, all these patients are paying money to us on a monthly basis, or this specific patient is paying this amount of money on a monthly basis or whatever. They had this procedure. This is what the reimbursement for that procedure is to the hospital. The hospital takes that portion or that fraction of the money and then gives it to related parties, the physician, the nurses involved in the care of that patient. So then that's how attending physicians get paid. So that's another distinction, right, between residents and attendings. So
quick question here. So, I mean, does it sound like you get paid according to the number of patients you see? Because I thought your salaries were kind of fixed, but if it's variable, which is depending on like the diagnosis or the number of patients and stuff like that, does that mean you can earn more and you can potentially double your income if you see more patients? In other words, I'm trying to figure out, is it like not commission based or like sales, but is it like a fixed salary, or is there like a bonus or profit incentives? Like, can you make more?
So that's a tricky question too, right? So you have people who are working in the private space, meaning that they own their own practices, and then you have people that are working under hospital systems. So in the US right now, the landscape is about 50% of physicians, once they're done with residency training, work for hospital systems. So we'll start with the patient or physicians in the private sector. So essentially for them, it's whatever whatever volume they. And again, it's a strange thing that the U.S. system is the way it's set up and the way reimbursement works. It's volume biased or volume based more than value based, and that's a huge sort of ethical debate that's going on right now and how physicians are paid. Because how do you go around and say, well, there's this patient that comes in, they might have a diagnosis. There's two patients, A and B. They might have the same diagnosis, but this one patient has a flavor of the diagnosis or has these other comorbidities of the diagnosis that makes their diagnosis a little bit more complicated, requiring more time, more resources. Yet you, the physician, you still get paid, the same amount for a patient that might have the diagnosis that has less. So that's how it's sort of incentivized, because you have these RVUs, and from my understanding of it, attendings, are paid on the volume of patients they see rather than the value of work, which is a huge problem in itself. But let's see, I think I lost my train.
You're talking about private and then people that work at hospitals, I think.
Yes. So then now people that work in the hospital system, there are salary negotiations. So there's a contract that's drawn out, and this is your sort of base salary, and there's arrangements, and those vary. From my understanding, there's arrangements, and those vary. Some people have they have incentives set up that they have RVU targets that they have to hit for them to be in accordance with their agreed contract. And then there's certain RVU levels that if you do hit, you get bonuses on top of it. Yes. And then my understanding is that there are caps though to these RVU incentives. So, and that's all sort of arranged at the negotiation table, what a hospital system is willing to pay you for services and so on and so forth.
So who exactly is negotiating? The hospital and the employees, or like the insurance companies in the hospital? Like who's negotiating?
So negotiations will happen between for attending will happen between the hospital, sort of the executive level of the hospital and the physician being hired. But there's sort of levels to it. You have the physician, you have the physician group, and then you have sort of the hospital executive suite, and then they report to each other. So a physician group within a hospital system might want to hire a new, attending, and they say that this is what, we've negotiated with the hospital, for payment of, or to pay you coming in. And then that's sort of arranged in that way. But then the hospital itself kind of negotiates sort of physician salaries with sort of the hospital's insurance office, and also Medicare, Medicaid, and whatever revenue that is generated by the hospital. It's all sort of arranged by sort of executive branches of the hospital.
Yeah. Oh, that's fascinating. And So in terms of, I mean, our audience probably doesn't even know what attending means. So maybe if you want to explain what the word attending means, but then even so, like what would an attending expect to make in their first or second year? And then someone that has like passed a certain threshold, what would they expect to make? Like in short, can you share a bit about the salary bands someone that's in this space can expect over their career?
Mm. So this is a great question too. Generally, it's all dependent on, it depends on, so salaries vary by field, pursued field. Um, so it depends on what you're doing. You have people in primary care and you have people that are in like specialty services, and they sort of bill differently. And you can only really look at it in terms of averages, because you can have, a primary care physician that makes, way more than a specialty care physician, or vice versa. So it can be very case by case basis, but on average, there are patterns of what to expect, as a, so you asked what an attending was. An attending is a physician that's completed their residency training and they're fully independent. So there are patterns or averages that could be looked up online for different specialties, what to expect, as a first year attending, or, what to expect as an attending that's had a 10-year practice, what to expect if you work within the private sector for a specific specialty, or if you work within a hospital system for a specific specialty. And then there are ways that people kind of supplement their base salary by doing other things, or that are, healthcare related. You might have partnerships in industry. You might be a researcher, in which case you might get a portion of, or added to your salary from the grants that you generate to do your research, and so on.
Yeah, no, that makes sense. I was hoping to get a few more like figures, like hard stats. Do you have any of those available? And it's okay if you don't.
Hard stats. It's really hard.
Like, would you say, all right, because I know you're on like the neurosurgery kind of like track, right? Like that's kind of the way you're trying to go. And like after 10 years of working in that space, let's say you've got all your certifications and everything, can you expect, is it 500K a year? Is it 100K a year? How much loans do people come out of college with on average for medical school? Is it 200K? Like, are there any stats you know of in general?
Okay, so stats for residency training, right? So, or medical training.
Yeah.
The average medical student leaves medical school with about 200 or $300,000 in debt. So it costs about $50,000 a year for training for over 4 years. So most students come out with a debt of $200,000, $300,000. Now, for residency training, the average salary of a resident is about $50,000. And residency lasts about 3 to 8 years.
Okay.
And $50,000 is a very, you would expect, like you mentioned, the idea, or the gestalt of medical training is that, oh, if you're a doctor, you have it set up, you should be, you're probably making a whole lot more. But when you look at the reality of it, with a resident salary, you're working about 88 hours a week at $50,000. That's about $12 an hour. So you're
Dude,
kind of
I
below
work at a
minimum
Starbucks.
wage. Yeah, you're working at minimum wage, and the idea is that, well, there's a return on investment on what you're doing, but there's this huge debate, that's still ongoing on, how we appraise resident salaries, and whether or not, or more, how do we increase resident salaries? So, and this is a conversation that has a little bit of history attached to it. So resident salaries themselves aren't paid out by hospitals, but they're paid out by the government.
Oh, really?
Yeah, by the government. So the CMS, the Center for Medicare and Medicaid Services, in 1965, decided that educational sort of activity within the healthcare space poses a benefit to healthcare for all in this country. So they decided that resident salaries should be paid out by the government.
Interesting.
Yes. So there is a portion of Medicare or Medicaid that goes into a large portion that determines physician salaries. In 1997, Congress decided to cap the number of residents in training. They said this is the amount of money we're willing to spend to train physicians. And I think it was something on the order of $10 billion or something like that, spread across 100,000, physicians. And so there's also this debate that's interesting now. You have medical schools that are expanding the number of seats because we're trying to meet the inevitability that in about 10 years, we're going to be short of physicians. There are not going to be enough physicians to treat, the growing healthcare population, the aging healthcare population. I think for specialty care, things like surgery, the number is projected to be something like 50,000 physicians. For primary care, it's projected to be about 75,000 physicians or so. So you have this bottlenecking that's happening. Medical.
Sorry, 50 to 75,000 that we're short?
Will be short of, yes.
Wow, okay.
Physicians. You have this bottlenecking that's happening. Medical schools are increasing their seats to try to meet this demand, but then on the resident level, the number of spots to train physicians isn't opening up. And that creates two big problems. You have people graduating from medical school, they did everything they were supposed to do. They took all the exams, they're doctors, but they can't get spots to get training. You have people that are in $200,000, $300,000 in debt who are trying to do this altruistic thing, and there's no avenue for them to continue their training. Then, okay, Congress has decided this is the number of physicians we want to pay, right? But then you find that hospital systems are largely run, educational centers are largely run by residents, and the value that the resident brings to the hospital far exceeds the monetary cost that the hospital pays out to physicians, which they get from the government. And for instance, there's a study, the American Society of Anesthesiologists recorded that over a 3-year period in an anesthesiology residence training, they generate on average about $1.3 million for the hospital, and then they cost the hospital about $300,000.
Oh wow!
So this wide margin. And then so in comes the debate that, well, if the government says that this is what they're willing to pay for residents' services, why can't the hospital step in or step up and say, well, we can then subsidize that pay as well if you're bringing this amount of value into the hospital system? So there's a huge debate.
That's pretty crazy. It actually reminds me of tech in a lot of ways. Most people don't know, but the average, if you took the total revenue of Google and divided it by the number of employees, each employee generates like $1.2 million for Google each. And so even if you're paying them $300,000 a year, you're still making 4 times that amount, right? As a company. And that on its own is mind-blowing, because you can actually pay someone $500,000, even $1 million, and you're still making money on them, right? So it's such a crazy system, but that's at least a for-profit kind of endeavor, because there's a bit of negotiating power, even though a lot of these companies were actually found to be colluding, where they would put in non-compete clauses, and some of these companies would kind of come into cahoots and say, we're going to set the benchmark of pay at this rate, so that no one really has that bargaining power. But anyway, aside from that, it's interesting to see the parallels in tech and how much is being generated on a per person basis. The differences in tech, someone can actually command a little bit more. They can charge their economic worth as opposed to, an attending or a resident. So what happens after that then? So after you're done with your residency, do you now gain that economic power to bargain, and that's when you get the astronomical medical salaries, or like, how does that work?
All right. So when you're done with medical training, right, you are then, it's just something to sort of decide that then your salary comes from, the hospital, the profits generated by the hospital. And in so doing, you sort of have, there's an element of, well, relatively speaking, you have increased bargaining power, because now you can go to different hospital systems and say, well, this is who I am, and this is the work I do, and what value do you ascribe to people like me who present this value, monetarily speaking. And that's when physician salaries actually go up. I mean, they're more than they can go as high as tenfold or 20-fold what you might have been making as like a resident.
Wow,
Yeah.
that's crazy. And I mean, you kind of mentioned it, the number of hours worked. So you're working 88 hours, or residents or attendings are working 88 hours, making as much as a Starbucks kind of employee. I mean, why would you stay in that field? Why wouldn't a lot of, especially in the context of the bottlenecks that you mentioned as well, there might not be enough spots. You've got all the student debt. Is it kind of like you're so far into this field, you might as well continue, even though you've sacrificed your 20s and 30s, you've made minimum wage, you've gone through all that, and it's like you might as well stay to get that light at the end of the tunnel. But I would imagine a lot more people would quit and just be like, look, I'm just going to go do something else with my time as opposed to doing this.
If I'm honest about it, I think there are a lot of people that are in a difficult position by the time they're done with their medical training and they've accrued so much debt, that you're sort of incentivized to go on or to carry on, because at the end of it all, there's a salary that's promised that could then help you pay off that debt. I think there are a lot of people that fall, within that category. And I think there's an economic reality to pursuing medicine that isn't fully appreciated, I think, until you're within, residency or within training after medical school. So you have a lot of people that I think fall into that sort of category. And then, I mean, you have a lot of people that are also interested in, doing the right thing. It is a very altruistic field. If you're someone who's interested in helping people and so on, it gives you that. But then, there are economic realities and costs that you pay for doing that. And it's just a matter of what's fair. If someone's working 80 hours a week, how do we, for very complicated, skills, I mean, the people that are laying hands on human lives and saving lives, there are years spent studying. There are board exams that are paid for, I mean, that run into the thousands just to sit down and take an exam, paying $2,000 out of pocket. There's so much that goes into it. And then how do we, as a society, then say that, this work is valued at something that's below minimum wage? So yes, it's a price. There's a hike in salaries after resident training, but this sort of space that we're in, where in residency you're being paid, it's an artificially set limit. We can pay value for services, and it couldn't really work, I don't think, in any other like industry in that way, where there's a certain value or a certain service that's met, but then the compensation for that service is far less. I can't think of many industries that are like that.
Yeah, it doesn't sound like the medical world is very free market driven. When you hear why the prices are so high, you hear things such as the government is not able to negotiate prices with, insurers and things of that nature. Now I'm hearing this as well. Things are capped, and it seems like it's a lot more or a lot less free market driven than you would have expected, even though it's still probably better than most of the world. That's why a lot of doctors leave Europe and other places in the world to come to the US, because they can earn a lot more. In fact, there have been a lot of strikes in the UK. I'm not sure if you've seen them, but, paramedics and
health services.
Yeah, ER, they're all like on strike because honestly, yeah, they're earning next to, nothing compared to the skill set they bring and their economic value. So yeah, it's good to hear from like the belly of the beast, from the inside, like what's actually happening and what the construct is. Off the top of my mind, I think that entrepreneurship might be a great avenue for those that have the knowledge and have identified the loopholes within that space to go and start a startup or create something new, because then you have unlimited upside, right? If you sell to as many hospitals, that's one way that I think you can uncap your earnings, or I don't know, your economic potential during that residency time frame. But as you mentioned, if you're working 88 hours a week, I mean, you're probably going straight home, like getting some ramen noodles on, and then watching like something on Netflix for half an hour, and then waking up the next day at like 4 a.m. to get back to work. So yeah, it's really a crazy system from the outside listening in.
Absolutely. And I mean, and even like getting home, you still have to, there's things to do. You still have to study for board exams. You might have to follow up on some, patient reading for the next day. So there's still work that even happens after after the the hours. And just to touch on what you said, so healthcare in the US is very much a profit-based system. It is for profit overall in the US, and there's a lot of money that sort of that healthcare generates. And one criticism, it's public known criticism, is the amount of compensation that players within the healthcare space make relative to other players. One of the huge divides is between like health insurance companies and actual like medical practitioners, doctors, nurses. The gap between compensation is it's a chasm. You look at the top 7 insurance companies within the US. If you look at their CEO revenues, these are people that may have not even laid a hand on a patient ever, are making. Here's a good example. The top health insurance company in the US is probably Cigna. Their CEO over 10 years, accrued a salary of $365 million over 10 years. Yeah, and that's sort of the numbers you're looking at.
And is he a doctor or she a doctor, or they're probably an MBA from somewhere?
Or an MBA from somewhere. Yeah, yeah. So then you wonder, like over 10 years, there's no physician job that accrues $365 million over 10 years. It doesn't exist.
Yeah, yeah.
So
It's crazy. I mean, even in broader society, even beyond the medical world, I believe it was sometime in the 60s and 70s, the CEO to average earner ratio was something like 1 to 30. And now it's ballooned astronomically. It's like 1 to 60, 1 to 100, and so the top is getting richer, and then everyone else is kind of treading water. Everything from even house prices. I saw something today where they were comparing the ratio of earnings to house prices in the year 2000 compared to the year 2023, and it was at like 3 point something. So 3 times your earnings could get you a house in, maybe not in New York, but in somewhere in the country. But then it went up to like 5.6 as of last year. It was like the highest in like 20 something years, So yeah, that seems to be happening everywhere. But as you mentioned, there's this perception that the medical world is more altruistic. It's about actually helping people. It's about, but it just seems that the reality of wanting to actually help people and the economic benefit of actually helping people are so distorted. It's so out of whack that I would love to see some equilibrium happen at some point, but who knows? Maybe ChatGPT will be the thing that equalizes it and makes you work half as many hours because you have this robotic assistant helping you that's giving better accuracy and things of that nature. So who knows? I don't know. We'll see.
Who knows? That's an interesting thought, though. Yeah. Maybe AI is the solution.
Anyway, we've had a good run here for about 45 minutes. We'll probably have you back on another episode, but if you have any parting thoughts, feel free to share it with the audience. It's mostly entrepreneurs, tech investors, venture capitalists that listen to the show. But thanks so much for being on the show, Mo.
Oh, no worries, Saka. I loved it. Yeah, I'd love to be back. Had a great time. If I had to leave with parting words for entrepreneurs, I guess, which are the main audience consuming the podcast, I think people who are interested in opportunities, especially within tech, for tech and innovation within medical sciences, should really do their work in finding physician collaborators. Those are the people that are going to provide the ideas that could be grown together, because there's business ideas and there's the medical ideas, and those things need to come together. I think that's my big sort of parting message if I had to give one to an entrepreneur.
Sounds good, man. Thanks. Cheers.
No worries. Cheers, my man.